All right, we'll go ahead and get started. Welcome, everyone. Good morning from Indonesia and all of these Southeast Asia countries, and good evening from Washington, D.C. Welcome to the last session of Day 2 of the Southeast Asia Regional Meeting. We hope that you've been enjoying all of the individual sessions we've had so far, and we're happy to have you. Virtually, of course, we would have preferred in person. I have the pleasure of introducing our panelists for this session. And the topic of this session is a very important one. We're talking about preparing academic health centers for the future with two subtopics on mental health, so health and wellness, and also on long-term planning. Our first panelist for today is Associate Professor Krishna Udaya Kumar. He is the founding director of the Duke Global Health Innovation Center, focused on generating deeper evidence and support for the study, scaling, and adaptation of health innovations and policy reforms globally. He is also Executive Director of Innovations in Healthcare, a nonprofit co-founded by Duke, McKinsey & Company, and the World Economic Forum to curate and scale the impact of transformative health solutions globally. So without further ado, we're going to start with Dr. Udaya Kumar. Please, the floor is yours. Thank you.
Great. Thank you so much for that kind introduction, and pleasure to be with all of you virtually. Good morning and good evening. I want to take just a few minutes maybe to set the context for a larger discussion, and that's the idea of long-term planning. So that's probably far from people's minds in the midst of a crisis around the world and a lot of retrenchment in the way that we're thinking about the health of our organizations and our teams. And I think we'll rightly so spend quite a bit of time thinking about that health and wellness component. And to put that in context, I want to start by really thinking about where we are in the field of academic health centers around the world. This is a topic that we've taken on for almost a decade now. And if you go back and look, as I reviewed in the last few days, some of our writing from 5 to 7 years ago, I think many of the same challenges remain as they did then. And we asked even 5 years ago this question of, do academic health centers really even face a growing risk of extinction, given the really powerful role that they play in health and healthcare, but also within economies and societies. But the fact that almost every part of the mission of our academic enterprise is continually threatened over time. So where do we find ourselves? No shortage of challenges. These are more from a chronic perspective of thinking about where the world is headed. If you look across the tripartite mission in healthcare delivery, much of the world is starting to recognize or already moving to the idea that we need to really think about health as opposed to healthcare. That it needs to be much more beyond acute care delivery and apply the principles of population health or value-based care, which many of our traditional academic health centers are ill-equipped to do quickly. And of course, we face cost pressures on the care delivery enterprise, both acutely in the midst of this COVID-19 global pandemic, but also chronically in terms of the sustainability of our cost basis. When we look at health professions, education and training, and other core part of our missions, there's often a lack of sustainable and long-term support for high quality education. And not only that, we know that the education models have to continually evolve. We need new models of curricula. We need to be able to go into much more team-based care and think about interprofessional education and training models as the way of the future. All of these take resources and new thinking to happen. Third, on the research enterprise, significant pressure around the world on external research funding, especially during economic downturns as we're seeing now, that becomes an even tighter squeeze. And what we often see is that our academic enterprises are are not necessarily right size in terms of the aspiration of our research enterprise relative to the clinical and education enterprises that can sustain them financially. And then finally, at the core of how we govern and organize ourselves, there is almost in every organization a lack of full alignment across the organization, across missions. There's a saying that if you've seen one academic health center, you've seen one academic health center. We all tend to have unique governance models and funds flow models, even though the principles are similar. And many of our organizations find it difficult and slow to bring about change. So really thinking about how we address these challenges in the midst of this global crisis we're going through is something that I think is going to be fundamentally important for many of our enterprises. In this context, again, many of our academic health centers around the world are still trying to define what they want to be in the future as they think about the work ahead and thinking about, and this is data from work that PwC has done in talking with more than 24 leaders of academic health centers around the world, and thinking about how strategically we're trying to position ourselves. And there are 4 categories here from which hybrid models are developed. The first is this idea that academic health centers can be product leaders, so differentiated high-end clinical services. The second is that we can be in the business of being a health manager, so really owning end-to-end the care delivery experience for our patients. The third is the idea of being an integrator, so being able to look at both the financing as well as the delivery side in taking on financial risk for care. And then the fourth is the idea of being an experienced leader, so really being best in class in terms of the patient experience. And you'll see here, there's not a consensus by any means of where different academic health centers are positioning themselves. Most often we see some combination of really leading with our differentiated clinical enterprise, especially tertiary and quaternary care, coupled either to trying to be a broader home for the care continuum, or starting to take on in the second column more of that payer risk in addition to our provider function. I find it interesting that if you look at the least common aspirations, they're all on the experience side. So I think we do experience challenges as academic organizations that are complex in being competitive in providing the best patient experience and customer service orientation over time. And of course, this is all context of where the world was headed and the conversations we've been having as leaders of academic health centers. And we know that in the midst of all of this, we're now dealing with, over the last 8 months or so, a huge global pandemic. And this has affected every country, every part of the world. Cases reported in 191 countries now. And in the US, we certainly have an enormous and growing burden of disease that we're quite concerned about. And if you look at the chart on the right, you'll see that this is a highly dynamic environment. So from Asia to Europe to the Americas to Latin America and back to Europe and North America, we see that there are ebbs and flows to the pandemic. And so this is not a single type of event where we're able to get a handle on it and move on. So this remains a crisis environment in much of the world. And we'll hear much more about that and how we're protecting our own workforce in health and wellness in a few minutes. But I want us to think about not just what we do day to day and week to week, but really how we leverage this environment to make the best decisions possible for the years to come. And there's a famous quote that's attributed to Churchill, but many others over time: never let a good crisis go to waste. And so recognizing that crisis also comes with opportunity, we need to deal certainly with the day-to-day issues, but what else can we be doing? And there are some positive aspects that we've seen come from this and from the response. And one small example I'll provide is the shift toward virtual care. We know that virtual care, telehealth types of models have needed to grow to be feasible for population health management. Many of our patients would prefer to have that, but many of our organizations have been very slow to adapt to those types of models. And yet in the midst of this crisis, we've seen what's possible. And this is data that some of my colleagues published showing our own experience at Duke Health. And you'll see if you look at the charts on the right-hand side, for both telephone visits and video visits, we were largely at 0 visits on a day-to-day basis prior to having shutdowns associated with the COVID pandemic. And you'll see that we quickly dealt with the technical challenges. We were able to figure out the financial model to make this work in the midst of a crisis. And we're now at thousands of virtual visits a day. And so this is good for our patients. It's going to be in the long term good for our organization. And so we've seen now essentially 3 phases. If you look on this left-hand side, in blue, what we see was a shutdown and a huge uptick in outpatient virtual care. And then a second phase in red as we started to fill up our hospital with COVID patients with a huge uptick in terms of inpatient demand for telehealth. And then in phase 3, what we're starting to see is a pent-up demand of unmet services because of the pandemic that's starting to come through in our virtual care enterprise as well. So I really want to leave us with some principles to think about. The first is how do we think of centering ourselves on vision and alignment in not just in crisis management, but in our long term. So now is a great time for us to really make sure and anchor ourselves in the vision for our academic health centers in a post-COVID world, and make sure that we're taking this opportunity to create stronger alignment. The second, the conventional wisdom often is to pull back, retrench in the midst of a crisis. But we see over time that the most successful organizations actually take the non-conventional or unconventional approach, which is not to pull back, but to push forward. So how could we accelerate the pace of change and use this as an opportunity and window to make more bold and often difficult structural changes now rather than putting them off as we have for many years? And can we use this also to become more nimble as an organization, be more adaptive in our planning, and be more in tune with our external environment going forward? And of course, invest in our people. And we shouldn't forever forget that health at the end of the day is about people. And a last piece of this is an idea around innovation. We are going to probably talk more about innovation, and we see the drive to innovation in the work that almost every academic health center is doing. But the need to invest systematically in innovation, I would argue, is one of the biggest things that we can do coming out of this. Here's a simple 2x2 in terms of how I think about how innovation works in an academic health center. So we can source innovation internally or externally, and we can apply it internally or externally. So when we are sourcing internally and using it internally, that's often our internal R&D engine of how we're creating new clinical services, how are we creating new models. When we're going inside out, that tends to be how we do tech transfer, commercialization types of activities. When we do outside in, this is much more about open innovation, about how we learn from others, how we actually support our strategy through innovation. And when we're looking out entirely, this is much more about our understanding of the external environment as a venture or external impact types of opportunity. And in the midst of this crisis, to make sure that we're better positioned for long-term planning, I would argue that the open innovation model, the outside-in innovation, is going to be incredibly important and should become more ingrained in the culture of our organizations to be successful in the long term. And I'll leave you with a model of long-term planning that we've adopted over time, which is a tiered model. So across our academic health center, we've developed a strategic planning framework. So not a rigid strategy, but alignment around the mission, the vision, and our values, but also clear goals and priorities over a 5-year period in our mission areas. And we recognized, in addition to patient care, research, and education, that community health improvement and our global engagement in global health are key components of the mission of an academic health center in the future. And really have called out everything we need to do to ensure that we're focused on our people and the culture of our organization. And then every one of our operating units, the School of Medicine, the School of Nursing, or clinical delivery enterprise, then takes on the task of aligning clear strategy and strategic plans with this broader approach. So this is a brief example of how we've approached this and are thinking about being responsive to crisis, while at the same time making sure that we're positioning ourselves for success in a post-COVID world. So thank you very much for the opportunity to give you a bit of our thinking around long-term planning. I'll stop here and look forward to the discussion coming up.
Thank you, Professor Udaya Kumar. That was a great presentation, very thorough and easily understandable for our members. So before I continue to introduce our panelists, I would like to introduce Professor Budi Iman Santoso, who is at Universitas Indonesia and their academic health system. He will be facilitating the Q&A portion of this session. So welcome, Professor Budi, and thank you for joining us. I will go ahead and introduce our next speaker, Dr. Regina Burba, and she is from the University of Philippines. Dr. Regina Burba is the Associate Professor at Philippine General Hospital and at the University of Philippines. She is the Chair of Hospital Infection Control Unit and the Chair of Antimicrobial Stewardship Committee and Executive Director at the University of Philippines and Philippine General Hospital. Dr. Burba is also the country lead investigator for the, excuse my pronunciation, Favipiravir clinical trial for COVID-19 treatment sponsored by the Department of Health. She will be speaking to us today on ensuring the safety of healthcare workers with the PGH experience. Dr. Burba, the floor is yours. Thank you. Dr. Burba, you're muted.
Yes. Good morning, everyone. I'm very honored to have been invited to speak to you about our experiences and the planning for preparing academic health centers for the future. So way back in March, we were actually asked to transform our university hospital to a COVID referral center. So around the time that we started to experience the first cases of COVID-19 in the country, we received a very important letter and request from our Department of Health. This is equivalent to the ministries of health that in your countries, asking our hospital to be a COVID-19 referral hospital. So this would mean that we needed to transform our very large government facility to a COVID center who would be manning and taking care primarily of a large number of COVID patients. Pre-COVID and up to now, in the 113 years of our hospital, we've been recognized in the country as the largest medical center and actually the National Referral Center for Health. And our buildings and our departments actually are able to cater to the needs of about 5,000 trainees for health. And this is supported by the 19 clinical departments in our very large hospital. So this is the University of the Philippines. It's state funded. And on the picture on the right side, you would see a statue in front of our College of Medicine. And this statue shows the nude female with flowing hair standing on top of a skull with a torch. And it represents triumph of science over death. On the left picture, you would see this iconic symbol of our university. It's a man facing upward with arms outstretched, symbolizing selfless offering of oneself. So it is in this background that we initially hesitated, but later on very willingly converted our university to what we call the COVID Referral Center. And to guide this very drastic transformation, we went back to what the WHO would say, that we needed to have as a base the science, the solutions, and the solidarity. So the very initial response to this chaos was just to create the very important COVID crisis committee, which sort of maneuvered and navigated the whole system into a successful story. And we had in the very core the infection control office that also guided our transformation, putting in place the essential components of such transformation, which included timely policies, training of all, access to important materials and equipment, and a keen sense of making sure that implementation is in place. And then we, later on, when we were more comfortable, we went into surveillance and continued research. So this is the Philippine General Hospital, a lot of buildings, and somewhere there we concentrated our COVID efforts to very large wards in the hospital. The rapid infrastructure changes had to happen very, very fast. We only had like a week to transform many of the large open wards to be able to accept the COVID patients who were waiting for admissions. And within a week, we were able to declare that our hospital, which is a teaching hospital, ready to accept the COVID patients. So if this was the look of our emergency room pre-COVID, very quickly we were able to transform them to what was acceptably COVID wards, COVID ICU, and COVID emergency room to make sure that healthcare workers were safe. We had to put in a lot of engineering controls in all areas of the hospital. And that included a lot of innovations. No? So initially, we didn't have the time and a lot of resources to put in what was traditionally accepted as the negative pressure areas, but being large open wards with large open windows, we were able to make sure that the requirements for good ventilation was put in place and ensure a safe air exchange of more than the required 12 air exchanges per hour. So this is what we tried to do. We really tried to control the ventilation and made sure that contaminated air all went into place. Administrative controls. So there was human traffic. We had to know where everybody were when walking through our COVID areas. And we made sure that there were safe places that people who were not seeing or not frontliners still were safe in their particular offices. And of course, some brave trailblazing measures that made possible safety of healthcare workers. This is what we did for personal protective equipment. We had what we call the risk-based levels of personal protective equipment. So we had what we categorize as level 1, level 2, level 3, level 4, depending on what kind of work you would do within the health center and how long you were going to stay in non-COVID areas versus COVID areas. So that meant for the staff and the trainees, a very clear distinction of what exactly they should wear depending on what kind of task they were supposed to do. So that was supplemented by reminders and training. We had to do this also fast and in an innovative way, making sure everybody had access to these training modules, which eventually became virtual at some point in time. One of the things we also had in place was what we called safety officers. So these were, in published literature, they call them trained observers. And that our staff when we started to be a COVID referral center. But having these safety officers guide you exactly, particularly when donning and doffing the PPEs, was really a big help and a big boost and one of what we call best practices. So all along the way, we had reminders. We kept everybody posted as to the new policies, and we tried to keep our frontliners up to date with new things. We call them adaptive policies. So there were some changes in guidelines that responded to new evidence nationally and globally, and we had to keep everybody up to date. So the efforts to keep staff safe was uh, a continuing process. We had this, for example, N95 fit testing, which in the pre-COVID era was a luxury to us. We didn't have the resources to pay up for this kind of fit testing for N95 masks. But because of the need, things fell in place and it came to be part of our basic requirements for going into the COVID wards. So being a COVID referral center entailed really huge manpower needs. So on a per day basis, we needed up to 350 healthcare workers to man the COVID wards that were put in place. We were seeing about 180 to 200 admissions per or admissions of COVID patients per day. So the need for manpower was so high. But nevertheless, we were able to maintain a high level of morale for the healthcare workers. And these are some of the photos. There was political commitment, there was leadership, and there was just harmony of efforts among different departments. So that was good. At some point, we needed to test our operations, whether they were truly safe. Most of the operations that we went through were actually innovations. So by the third month of our COVID operations, we decided to test, to have a hospital-wide COVID-19 testing to see whether indeed our operations were safe. And we thought that surveillance of healthcare workers, testing them, whether they had COVID or non-COVID, based on a PCR test of the nasopharyngeal swab was done. And for the first time in the history of our hospital, we had this unprecedented, very high participation of this surveillance effort. In the past, we usually would get something like maybe 30% to 50%. But for this particular COVID-19 surveillance, we had up to 95% of our healthcare workers lining up to get themselves tested. And the hospital-wide surveillance at the time did confirm that our operations were safe. We only had like 2% of the 4,871 testing positive for the COVID-19. So in some areas, actually, we had only about 1.2 to 1.8%. So that was very good. And throughout the university, in the colleges that were just around the hospital, there was just a unified effort. Uh, Residents, fellows, nurses from different areas would put in some hours to be frontliners in the COVID wards, and there was just an enormous amount of volunteers. We also had we had also to put in place a very active and vigilant information and education committee to make sure that we were reaching out to all the staff and feeding them with up-to-date information. So in time, everybody was just involved, all hands on deck for healthcare workers. Even spiritual support, mental support, and even skincare support was present. So we also invested, the university also invested on the telemedicine that was described earlier. This was the operation center that initially was a depot for volunteers and donations, and then later on it expanded to supporting the telemedicine efforts. So in time, it was accepting consultations from various patients through different departments. These are pictures of the enormous amount of donations from various groups. And the support extended beyond the duties of the healthcare workers. So I think as you said, health is all about people. So when people actually volunteered to be part of the COVID operations, we had to support them with transportation because there was a lockdown. So transportation needs were addressed, and also accommodations needs were addressed. So some of the colleges, because there were no face-to-face school at the time, so some of the colleges were actually converted to dormitories so that our needs for accommodations of healthcare workers very close to the hospital would be met. And other neighboring universities also pitched in and helped us with this. So some people actually started to give a different meaning for PGH, which is Philippine General Hospital, when they started to say maybe PGH meant more people giving hope. And we soon recognized that people are really our most valuable resources. So through all of this difficult times with the pandemic, we helped them manage their fear, we kept them informed, and we kept them protected and comfortable. Through all of the pandemic and despite the pandemic, we had to make sure that we continued to have excellent service for our patients. So service, the triad that we have in the hospital and the university, service, training, continued, and research in the university continues to actually flourish. There's been this great amount of proposals and protocols that have been approved for research related to COVID. And in terms of future planning, this is the future COVID isolation complex that we have been planning to put up, and actually it's soon going to be opened, maybe around the first quarter of next year. This is will have state-of-the-art all the needs that isolation complex entails. This has been put in the planning, and we're really looking forward to having this in our university complex. So in summary, to maintain healthcare worker safety for academic health centers, even during a pandemic, we need one, a political commitment from university leadership. Number two, strong infection control measures and equipment. Number three, very important, innovations within an adaptive design. And number four, cooperation of colleges, departments, faculty, trainees, and students. We need continuing support, reminders, orientation for staff. And number six, despite the pandemic, we really need to pursue excellence in the delivery of service, training, and research in the university. So thank you very much for your attention.
Thank you, Dr. Burba. That was a very dynamic approach that you shared with us, and it's great to see how proactive your institution is in this time. And now, continuing on the topic of health and wellness, we will continue to our next speaker, Dr. Michael Wilkes, Professor of Medicine and Global Health and Director of Global Health at the School of Medicine at the University of California, Davis campus in the US. He is widely known for his creative efforts to introduce medical students to the humanistic side of being a physician, and for working tirelessly to include the public health and social sciences as part of training physicians. As the Vice Dean for Education at the University of California, Davis School of Medicine, he led the way in innovative changes in medical and health sciences education at the campus and across the University of California and around the world. In his current capacity as Director of Global Health, he works collaboratively across the University of California Health Sciences schools and around the world. In this region, he is actively involved in the USAID Southeast Asian One Health University Network in developing e-learning tools and software for shared use, which I'm sure will be much interest for our members in this region. He will now deliver a presentation titled COVID-19 as a tool to re-examine the wellness of our team. Dr. Wilkes, the floor is yours. Thank you.
Thank you. Can you hear me?
Yes.
Okay, excellent. Good morning, everybody. It's a pleasure to be here and a pleasure to hear our first two speakers. Dr. Burba spent time at Philippine General Hospital, and it is truly an amazing place with an amazing mission, staffed by amazing clinicians, doctors and nurses, and all sorts of others. What I'd like to do in the next 10 minutes is talk a little bit, not so much about COVID and not so much about PPE, but about our staff, our students, our nurses, our pharmacists, our physicians, et cetera, et cetera. It is important to recognize, I think, that all of us wear many hats. Some are deans and clinicians and researchers and teachers and mentors, and most of us are family members, where we are a spouse and we have children, we have sisters and brothers and parents. And it is increasingly hard in a COVID epidemic to balance all of these different parameters. It is important to recognize that we have factors affecting clinician well-being that include cultural factors and our roles, and personal factors and economic factors and learning and the like. So why focus on the resiliency and wellness in times of COVID? First of all, our staff are working incredibly hard, as we've just heard. They're being pushed to be innovative, they're being pushed to be productive, and being pushed outside of their comfort zone. Secondly, often our staff is scared, scared about being sick, but also scared about bringing sickness to their own home and infecting their family and loved ones. And our staff needs to feel protected. They need to feel as though we care about them, that they are as important as our patients are, and our patients are very important to us. Our staff need to be feel as though they're cared for and that they are appreciated. So it is not surprising to those of you listening that burnout, even before COVID, was common. At least, well, somewhere between a quarter and half of practicing physicians report burnout. Medical graduate trainees, we call them in North America residents, 45% of medical students. And our physician burnout is twice as prevalent in physicians compared to age matched controls. Why is burnout important? Well, first of all, it leads to emotional exhaustion. It leads to depersonalization, which causes our providers perhaps to be negative and cynical and to treat patients and families as objects rather than people. It gives us a low sense, feeling of personal accomplishment, and it drives people away from the profession. We've had enormous numbers of retirements in North America over the past 6 to 9 months. And lastly, at least in North America, suicide, again, is twice as common amongst physicians as educationally matched groups, so others who have advanced degrees. Causes of burnout can be individual and they can be external. Today, I'd like to focus a little bit on the external, what's going on in our systems. Those system attributes have to do with how hard we're asking our staff to work, how much autonomy and control we give them, how we measure the quality of their work, what kind of support do we give them in terms of recognition, and how we punish them or admonish them when they're not doing as good as they could do. The consequences of burnout, I won't read this to you, but you can see they're profound. They are at the personal level and the family level, and the worst that happens is both patient care drops, and also we lose people from the profession because they feel as though they just can't handle the work emotionally, or from a work requirement. So we talk about sort of three reciprocal domains of physician well-being, and this relates to other professions as well. We've got the culture of wellness. We've got efficiency of practice and personal resilience. As we talk about each of these, let's talk first about efficiency of practice. This includes workplace systems, it includes processes and practices that help leaders and their teams to engage in compassionate, and in the case of COVID, in other cases, evidence-based practice. The culture of wellness is how the system creates and promotes values and attitudes and behaviors that promote self-care, personal and professional growth, and compassion. And lastly, this idea of personal resilience. These are a set of individual skills that we can teach and we can promote that relate to behaviors and attitudes that contribute to personal, emotional, and physical well-being. Resilience, I think many of us would agree, is something that can be learned, and it can be reinforced even in people that don't have strong resilience to begin with. How do we do this? We can practice gratitude. That means stronger immune systems and lower blood pressure. It will lead to higher levels of positive emotions, more joy, optimism, and healthy and happiness, acting with more generosity and compassion, not only to patients, but to each other, less feeling of isolation, less loneliness. And the last thing I want to talk about for a moment is mentorship. And it is something I think that we don't spend nearly as much time talking about and cultivating. We talk in medical education around the hidden curriculum. It is what people learn from watching us, how we behave, how we relate to each other, how we relate to our patients. And the role of the mentor can be sneaky. Sometimes we carry the title of mentor, but other times we're a mentor just by the position that we're in, or perhaps the gray hair that we have, or the age that we have. And mentorship can be extremely helpful at all stages of careers. We often think of junior people, medical students and house staff as needing mentors, and they certainly do, but so do mid-level career employees, and so do senior career employees. And we often have people retire and leave the ship and go off and never return again. And very often senior leaders have enormous amount to offer in terms of mentorship. Mentors can be hard to find. I don't think mentors are always born. They can be trained, and they need not be experts in a content area. They can be experts at interpersonal skills, etc. A mentor is more than a role model. A mentor is a guide, a coach, a champion, a support. And frequently the staff need a triad of mentors, someone above them, perhaps somebody who's a peer and can give them advice. Anyways, in closing, I just want to make the point that COVID has given us an enormous amount of responsibility that we have to each other to keep each other safe, to our patients and to society. But it's too easy to forget that our systems, while they're geared toward high productivity and high turnover in terms of keeping people safe, getting them well, and discharging them, that those of us who work in the hospital are there for long periods, and they need just as much care and nurturing and attention as do other human beings that we're caring for. So I'll close with that, and am happy to answer questions in our discussion period. Thank you.
Thank you, Dr. Wilkes. That was an excellent presentation, and it's nice to see the humanity side of this whole situation be brought to light. Last but not least, we have our speaker who will continue to talk on health and wellness, Dr. Nusati Ikawahju, who is the Director of Human Resources, Education and Research at Dr. Sarjito General Hospital as the member of Academic Health System at Universitas Gadjah Mada in Yogyakarta, Indonesia, and has been working there since 2019. Her career at the General Hospitals began in 2006 when she was the head of supervising medical services at the Fatmawati General Hospital and successfully appointed as the Director of Human Resources, Education and General Affairs at the Fatmawati General Hospital in 2017. She is also the Deputy of General Secretary of Association of Indonesian Teaching Hospitals and member of Hospital Accreditation Committee. She will deliver the last but not least presentation today on keeping our healthcare workers safe. The floor is yours, Dr. Nusati. Dr. Nusati, you're muted. There you go.
Thank you, Mrs. Habibah Osmani. Good morning, ladies and gentlemen. I will present our experience and strategy to keep our health workers safe in the period of COVID-19 pandemic. And to begin with, I would like to shortly introduce our hospital to you. Dr. Sarjito General Hospital is a state-owned hospital under the Ministry of Health, Republic of Indonesia, a national referral hospital which has been certified an academic medical center since 2014 and the main teaching hospital for and member of academic hospital system of the Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada. These are the services and facilities. And the hospital employs almost 3,000 people consisting of doctors, nurses, midwife, nutritionists, other supporting clinical human resources, and non-clinic employees, and 1,100 residents. Every month, we cater around 41,000 outpatients and 2,850 inpatient before pandemic. During pandemic, we cater 32,000 outpatient and about 150 inpatient before, in 2,150. During patient, during patient we cater 32,000 outpatient, about 20.84% decrease, and 2,150 for inpatient, about 24.15% decrease. We focus on the safety of our health workers because they are the core human resource of the hospital and our main investment both for educational and clinical duties. Therefore, their safety is our priority. When COVID-19 also reached Indonesia, we start to assess the potential COVID-19 exposure. Does the work setting require close contact with people potentially infected with the COVID-19? Do specific job duties require close, repeated, and extended contact with people with known or suspected COVID-19? Has the community spread the virus, included cases in the hospital? Besides that prior assessment, we also refers to CDC and the State Health Department guidelines to protecting our healthcare workers. In the current and past coronavirus outbreaks, healthcare workers have had a high rate of infection. It is absolutely important to ensure that procedure, equipment, and training for the healthcare workers are fully protective. These are the key steps to prepare and manage epidemics in our hospital. Promoting like education, hand hygiene, physical distancing, wearing face masks. The second one, implementing preventive measures such as immunity increasing, vaccination, and providing food supplements. Preparing for the curative treatments, we have a COVID-19 hotline for health workers, facilitated by K3 unit, Occupational Safety and Health Unit. And the last one is managing post-epidemic recovery business like that normal life and normal activities. We want to eliminate the COVID-19 by removing this hazard from our hospital. Unfortunately, it is too complicated to overcome. Then we reduce or even minimize this potential hazard by engineering controls completed by administrative control, which will change the way people work, including the wider use of PPE to protect the health workers. This is what we mean by engineering control as to preparing negative pressure isolation rooms, HEPA filtration, portable HEPA filtration, swab chamber, seals, and other barriers. Besides, we also need to do administrative control and work practices to reduce the exposure. For example, to determine work from home policy, minimizing contact among workers and clients, limitation on the number of staff present, particularly for those with high potential exposure tasks, modify our standard operating procedure on healthcare, preparing some training to convert our workers to the new situation. This is the zone engineering regarding the COVID-19 healthcare. Those places in red means the high risk areas in order to minimize the COVID-19 spread. Soft barriers are applied, for instance, the use of ropes, signs, and floor marking to maintain physical distancing. This is also access control and clinical screening for those who comes to our hospital. To enhance our control, we also made a joint decree with Universitas Gadjah Mada on clinical learning protocol during COVID-19 pandemic adaptation at Dr. Sarjito General Hospital, network hospitals, and the Faculty of Medicine, Public Health, and Nursing Universitas Gadjah Mada. Some training are organized and tailor-made for our health workers related to COVID-19 treatment, and even on applying the PPE standards, because we involve many more health workers to support the COVID-19 patient care. For example, we have a trained employee on how to don, put on, and doff, take off PPE, train workers to maintain, store, and replace PPE, provide medical evaluation and fit testing. This is the diagram on the screening on the employees. 90.5% specialists are already screened. And yeah. And there is 80.5% residents who are already screened, and so on. Diagram of COVID-19 screening at Dr. Sarjito General Hospital. In general, there are 74% health workers who have already been screened. There are 26% more to go on screening. These are among residents who have already been screened based on their departments. Since month September, we have implemented the new normal safety supervision in our hospital, which is also applied in any other hospital. In our hospital, we make some extra effort in order to change our worker nature and habits, like reducing the width of the space into more slender to allow only small number of people who may share the same room. It has almost a year already that we are still combating the pandemic. However, we keep going on hand in hand to keep our health workers safe. So far, there are 67 health workers out of 5,000, including the resident, or about 1.35% confirmed COVID-19, but they were all cured. The local transmission we brought by the family members, friends, and outside contacts. There is no death case until today. Keep controlling the obedience on implementing the health safety and on staying vigilant are parts of the efforts to keep our health workers safe. Thank you for your time.
Thank you, Dr. Nusati. So that is our last presentation for this session, and we will now move into the Q&A portion, which will be facilitated by Professor Budi Iman Santoso. Professor Budi? Oh, you're muted.
Thank you. Yes. Thank you, Habibah, for your lovely introduction. And now we will read the question from our attendees. And please, if you have any question, you can still insert in the Q&A feature at the bottom of in your screen. Okay, it's not maybe for the make the time for the all panelists. We already give a very excellent presentation. Is what about the academic health system must be continuously evolved to meet the needs of the patient and society. How do you see centers and systems involved in your countries or community after an experience like the COVID-19 pandemic? Please, maybe from the Professor Krishna Uda Yakumar, time is yours.
Sure, thank you, Professor Budi, and such a pleasure to hear about the great work happening from the other speakers as well. I do think the impetus on our academic health centers to think about what a post-COVID world looks like and the role is very important as part of this discussion. I would say a couple of key trends. One is we need to really think about what our patients want from the health system. I think too often historically, as we've developed academic health centers, they've been founded on hospitals and clinics and physical care, when we know that new models and future models are really going to be much more about how we create a digital interface to our patients, how we think about virtual care, and moving to a much more population health-based model. So for us to evolve our academic health systems to be more fit for purpose, I think is really important. A second role, which we've touched on a bit, but I think it should be explicit, is that academic health centers play a critical role in communities as a trusted source of information and of research. And as we're starting to see the pandemic evolve and the emergence of potential vaccines, but at the same time, we're seeing the rise of misinformation, disinformation, vaccine hesitancy, and the like. I think there is a strong role for academic health centers to be trusted sources of information and to combat misinformation about what's happening in the pandemic across our local communities.
Thank you, Prof. Kumar, from sharing your experience and your explanation. And for Dr. Regina Berba, please,
on my end, I think it's important for us to realize that even health education cannot be completely virtual. So there will be a component wherein we really need to get our students back to our centers, to our hospitals, to see live patients. I think it's impossible to be good doctors, good healthcare workers without really seeing patients. So, but in this light, we really need to keep on working on making sure that the institutions wherein we will be putting them into would be safe for them. The reassurance that we are trying to make the system work and safe needs to be there for them to trust us. So that's my take on making sure that our academic centers continue to flourish despite the presence of the pandemic threat. Thank you.
Thank you. Yeah, thank you very much, Dr. Berba, for your interesting explanation. So please, for Professor Wilkes, time is yours.
Well, thank you. Time has never been mine before, so it's nice. There are two comments I'd like to make. One, building on Dr. Berba, we have in many cases lost the public's trust. Part of this has to do with the way we've communicated information, and part of it has to do with the information that has been communicated. And so I think that as we leave the COVID epidemic or pandemic behind in the months to come, we have a lot of trust building to do. And I see that the major work and the major transformation won't be in the area of technology, I think. It will be in the realization that health of a community is far more than medical care, right? It involves housing, and it involves food, and it involves education, and it involves climate change. And that if we as a world are going to be healthy and our communities are going to be vibrant and healthy, that academic health centers need to see themselves as far more than deliverers of medical care, but really champions of health for the population.
Thank you, Professor. And now, the last is not least is Dr. Nusati. Can you give some your comment?
I'm sorry, Dr. Budi. Could you please tell me the question? Because
Yeah.
your voice too weak.
Yes.
I could
Pada intinya adalah bagaimana dari pengalaman terjadinya pandemik ini terhadap society, bagaimana untuk meletakkan continuously-nya, mempertahankan continuously yang dibutuhkan untuk pasien-pasien kita ataupun terhadap organisasi kita dengan pengalaman terjadi pandemik COVID ini. Can you listen?
I'm sorry, we have a trouble here.
Okay. I think we have the time. So once again, now we are reaching the end of our session. It has been such a delightful experience and discussion. Thank you once again for all the panelists for sharing your experience, and to all the attendees for joining this session. To officially end our regional meeting, I would like to welcome Dean Professor Ari as the Dean of the Faculty of Medicine, University of Indonesia, and Regional Ambassador of the AAHCI Regional to deliver his closing remark. Please, Dean Ari, the floor is yours.
Yes, thank you, Professor Budi, for a wonderful session. And then also thank you, Dr. Berba, Dr. Michael Wilkes, and also Dr. Nusati and Dr. Krishna for your presentations. So we are still morning here. Good morning, everyone. Now, as we have reached the end of our AAHCI Southeast Asia Regional Meeting, I would like to convey my greatest appreciations to all the panelists and facilitators for your kind contributions. All the attendance, it has been a pleasure being with you all. I hope our regional meeting beneficial for you to have a better understanding about the work of academic health centers, especially during COVID-19 pandemic. I would like to also invite your institution to be our members of associations of academic health center, to not members, and to benefit from a fantastic network of other peers, leaders worldwide. And also I would like to say thank you to our headquarters staff, Habiba and Christine Smith, for your help and support our regional meeting this year. And thank you, and see you all regional meeting next year, which I hope we can meet in person in a better situation. Thank you for your attention. Stay safe, everyone. Thank you.
Thank you.
Bye-bye.